Hello and welcome to the Point of Care podcast. Today's episode is on altered mental status, running a rapid response. As a first impression when you walk into the room, get a sense of what their mental status is and whether they're in any acute distress. Also, note their general appearance, specifically looking for an obvious facial droop. Look for tachypnea and increased work of breathing, including nasal flaring, retraction, tripoding, and cyanosis. You should ask yourself whether the patient is protecting their airway. Get a sense of the patient's current oxygenation. What are they hooked up to? Are they getting better? Do you need to intubate them? And is this patient at risk of coding due to hypoxia? For initial stabilization, if the patient is non-responsive, check their pulse and start the ACLS algorithm if there isn't one. You should also be wondering if you need to intubate if they're not protecting their airway. Always get a glucose and check for hypoglycemia. If they are, push D50. Wonder about opioid overdose. You should give Narcan, naloxone, 0.1 milligrams IV and repeat this every 3 to 5 minutes if there's no response. A respiratory rate of less than 12 is the best indicator, whereas meiosis versus normal pupils is not a reliable thing to find on your exam. If the patient's in respiratory distress or is hypoxic, put them on non-rebreather 100%, bump them to high-flow nasal cannula if that's not working, and consider whether or not they would benefit from non-invasive positive pressure ventilation or if they just need to be intubated. Things that can tip you off include a PaO2 less than 60 on ABG despite non-rebreather or high-flow nasal cannula, and a PaCO2 over 45 despite things like BiPAP. A pH less than 7.25 and a process that's irreversible is likely something that will tire the patient out as they're trying to blow off CO2, in which case they might need to get intubated. If the patient seems like they're having a seizure, push Ativan 2 milligrams, call neurology, and discuss loading with an anti-epileptic like Keppra. If the patient's hypotensive or you have concerns about an infection, give fluids like LR, send a basic infectious workup, start antibiotics, and a pressor if needed. If there's concern for Wernicke's encephalopathy, give IV thiamine. If there's hyperactive delirium or agitation, you can give Haldol 2 to 5 milligrams IV versus 0.5 to 1 milligram PO or Seroquel PO. If the patient has severe hyponatremia, call renal and consider hypertonic saline pushes if it's severe and there's concern for cerebral edema. If there's a known CNS mass or edema, call the neurosurgery team and consider giving glucocorticoids. As an intake and your general assessment, get a sense of why the patient's in the hospital, what their relevant comorbidities are, their baseline mental status, their last known normal, the acuity of their change, any recent meds they've gotten, including today, what their current access is, and their code status and decision makers. On your exam, of course, always focus on their vitals, their hemodynamics, their oxygenation, and their respiratory rate, and look for red flags for early intubation. This includes pooling secretions, hemoptysis, or respiratory distress. If they're awake, check on their attention, their ability to follow commands, and look for any specific focal deficits on your exam. If they're not arousable or not following commands, check their pupils, see whether they're localizing to pain, and see if they're posturing. Other things that you can be on the lookout for include rhythmic stereotypical movements, tongue biting, incontinence, or evidence of asterixis. For your workup, be thinking about the general differential of MIST-D. First is metabolic. Get a point-of-care glucose, get a VBG-ABG, a CMP, and you can consider a TSH or cortisol if you have suspicion. For infection, get a CBC, send off a blood cultures, lactate, get a chest x-ray, and send off urine for urinalysis and urine culture. For S structural, get a head CT, and consider calling a stroke alert if there's anything focal on their exam. You can also consider an EEG if there's concern for underlying seizures. For T toxin, check their MAR and do a medrec. Have they abused any opioids recently? Any anticholinergics, antihistamines, benzos, antidopamines, or insulin? You can also consider a UDS if this is a new patient. Metabolic causes of altered mental status include hypoglycemia, electrolyte abnormalities like hyponatremia and hypocalcemia, as well as uremia, hypercarbia, hypothyroidism, or adrenal insufficiency, and hepatic encephalopathy. Infectious causes include UTI, pneumonia, bacteremia, or meningitis and encephalitis. Structural causes include ischemic stroke, hemorrhagic strokes, seizures or post-sickle phases, and a CNS tumor. Toxins include opioids, alcohol or benzos, and iatrogenic causes, like medicines received in the hospital. Delirium is defined by an acute, fluctuating, and inattention. Think about this if the patient is elderly, they have a history of dementia, prior strokes, any visual or hearing impairment, whether they're depressed, and remove possible offending meds if you have a concern. That's all for this episode. Check out pointofcaremedicine.com to see the templates we discussed, as well as the pearls, literature, and links to other resources.